Welcome to the South West London Committee for Collaborative Decision Making, our first. Please note that our proceedings today are being filmed and recorded, that we have a microphone system in use. When you speak, please switch the mic on. When you finish, switch it off. And when we get to questions from the floor, we have a roving microphone that will be run around. Thank you. Members are seated with their CCG colleagues today and have nameplates in front of them. We have had one substitution. Karen Worthington has replaced Andrew Murray from Merton, and it is Tom Chan, not Tony Chan, from Croydon. Thank you. I will now ask members to go around and just say their name to identify themselves for the film. If you'd start around that end. Joe?
Adrian Attard, Sutton Health Watch.
Jimmy Gillespie, Wandsworth Health Watch.
Chris Elliott, Sutton CCG.
Jeff Croucher, Chair, Sutton CCG.
Susan Gibbon, Sutton CCG lay member.
Naz Giovanni, Chair, Kingston CCG.
Tonya Michaelides, Managing Director, Kingston CCG.
Susan Smith, lay member, Richmond CCG.
And we're expecting Kate.
We're expecting Dr. Kate Moore, who will be standing in as the clinical chair tonight.
James Murray, Chief Finance Officer for South West London Alliance, representing Richmond.
I'm Carol Varl, I'm lay member Wandsworth, and I'm the convener for today.
Tom Chan, Medical Director, Croydon CCG.
Philip Hogan, Croydon CCG, lay member.
Andrew Ayres, Accountable Officer, Croydon CCG.
Claire Gummett, Merton CCG lay member.
Karen Worthington, Merton CCG, and I'm deputising for Dr. Andrew Murray this evening.
Sarah Blow, Accountable Officer for South West London Alliance and for Merton CCG tonight.
Stephen Hickey, lay member, Wandsworth CCG.
Nicola Jones, Chair of Wandsworth CCG.
James Blythe, Managing Director, Wandsworth CCG.
Tony Brzezinski, Clinical Lead for the South West London ECI programme.
I'm Jonathan Bates, I'm Director of Commissioning Operations for the South West London Alliance.
Nikki Williams, GP in Wandsworth.
Zolly Zambo, South West London STP, ECI Programme Lead.
Thank you. Now some housekeeping. We are not expecting a fire alarm test this afternoon, so if the alarm sounds, treat it as real. We have fire exits there and down there, I think. Certainly down the stairs, over by the lift. And toilet facilities are around the corner opposite the lifts. A register of interests of members has been compiled and is available today. Do I have confirmation that each member's correct entry is recorded?
My interests have not been recorded, but I can give them in, but I don't think there's anything that would be relevant to the agenda this evening.
Here's how I propose to manage today's proceedings. We'll first deal with our terms of reference. Then Jonathan, Tony, and Nikki will, in various permutations, present their report on an outcome of the effective commissioning project. Please note any comments and questions as they proceed. I will seek questions at the end. I will then first ask each committee chair, that is, and I should say, those noted as chairs here today are not necessarily chairs of the CCGs. They are chairs of the CCG membership here tonight. I will then ask the chairs here tonight for any initial comments, and then I will open the floor to all CCG members as well as Health Watch and public representatives. At the conclusion of the discussion, I will ask the committee to agree the policy, and following the committee's decision, I will open the floor to questions on today's agenda from members of the public, with priority given to any written questions received. I will then close the meeting. Is that okay with everyone? Thank you. Terms of reference. Get the right bit of paper. The terms of reference for the South West London Committee for Collaborative Decision Making were approved by CCG governing bodies and have been added to their constitutions as per the schedule attached, governance and reporting section. Are there any questions on this document that has gone through each of the CCGs? The committee is asked to note the terms of reference as previously agreed by their CCG governing bodies. I take it that everyone agrees. Thank you. Over to the presentation. Thank you.
Thank you very much, Chair. So what I'm going to do over the course of the presentation, together with colleagues sat here, is talk through the journey we've been on over the last 6 months to develop a effective commissioning initiative policy, and I'll go on to explain what that is in a moment. So that's what I'm going to spend the time doing, and at the end, what I'm asking the committees to do is sign off an agreed policy across South West London. So hopefully colleagues have got the slide deck in front of them, and they can see the structure to the presentation on the introduction slide, beginning with me saying and describing what an effective commissioning initiative policy is, how we've developed the latest version of this policy, how we've gone through a process, a very clinically driven process, I must emphasise, of ensuring alignment and participation of a wide range of stakeholders in the development of this policy, including patients. Some new clinical thresholds that are in the document, the measurements of equality and the impact it has on local residents, next steps in where this work will progress from where it is at the moment, then an opportunity, as Chair has already said, for questions, and then the sign-off process. So starting at the beginning, so what is an ECI? What does ECI stand for, and what is ECI? So it stands for Effective Commissioning Initiative. There are a range of similar terminology used, or differing terminology used across the NHS for what we're talking about. So sometimes it's called procedures of limited clinical effectiveness in other parts of London, or treatment access policies, or a list of procedures, restrictions, thresholds in Surrey, or indeed choosing wisely in some parts, including some CCGs locally, though often choosing wisely incorporates medications as well, which this policy does not. So we've chosen to stick with the terminology actually developed probably a decade or so now ago of calling it the Effective Commissioning Initiative. And so what's in the policy? So what's the scope of the policy? So I think it's really important to say it's primarily around planned care procedures for patients, and within that it's mainly surgical procedures undertaken by the NHS. And there is a total of 57 procedures that are set out in the document. And it's about ensuring fair and equitable access to those services. What it doesn't include, and I think this is really important to be clear about, is urgent and emergency care procedures, patients who have a diagnosis or a suspected diagnosis of cancer, and women requiring maternity care. So all of those sit outside this policy. And I think it's also really important to iterate that even if people do not meet the thresholds within this policy, there remains a process of individual funding requests for any patient across South West London to seek access to treatment if they have exceptional circumstances. So it's really important to note that we've built that fail-safe into how we've designed the system across Southwest London. So the Effective Commissioning Initiative policy was originally developed by Primary Care Trust, so the predecessor body to clinical commissioning groups, some 10 years or so ago, and they faced similar challenges in terms of variations of care across the patch, across their local communities. And they also faced the financial challenges that we face as a system. And they also wanted to embed best practice and good practice based on clinical evidence that has been an increasing driver in what we do over recent times. So you're with us? Okay. So the original policy was signed off by Primary Care Trust back in 2006. I think it's probably fair to say that we haven't kept the policy as live and relevant as we could have over the intervening years, and also to say there's been some variation in where we've ended up in different primary care trusts and subsequently clinical commissioning groups. So we've come together and we made a commitment, and many clinicians across South West London made a commitment to come together to try and create a revised policy which has greater consistency and eliminates postcode variation for local residents. So hopefully I've explained a little bit about what the policy is, how we've created it, and to emphasise it's based on evidence and based on what is clinically effective. So if I move on to say where we are with version 2, and I really do want to thank so many people, because there's been a vast number of people involved in the development of this policy, and it was really encouraging to talk at the Clinical Senate recently with 40 or 50 senior clinicians across the system, and just hear how positive they felt about how engaged they've been involved in this process, and how their organisations have been effectively involved, and how we'd structured it well and listened to feedback. And I particularly want to ask colleagues, say thank you to colleagues surrounding me, so Dr. Brzezinski, Dr. Williams, and Zoli Zambo as well, for their input into that process. So in terms of what we did through the development of version 2, so it was really about aligning and clarifying existing clinical thresholds. So as I said earlier, there was variation across South West London, and we've sought to bring alignment so that patients in different boroughs will have the same access to care and to treatment. We also recognise from feedback from clinicians the document wasn't as user-friendly as we might have wanted it to be. So we've spent quite a lot of time trying to make it something that is valuable to the system and usable by primary care clinicians, by specialist doctors too, and something that's relatively straightforward. And part of our communications campaign will be also how we present this very much more widely to the public too. We based it on existing evidence-based clinical practice, and we had the input of a specialist public health consultant, or experienced public health consultant, who looked across England at what the evidence base was in support of this work. So most of the policies you see, or most of the procedures described in the policy, were already in the previous version of the policy. However, there are a few new areas where National Institute of Clinical Excellence, NICE, or indeed where it's a new responsibility for CCGs to commission, has made us think again about whether we ought to have a policy in that area. But it has always been based on sound, robust evaluation of the evidence supported by the local clinical community across South West London. We very consciously at the outset chose to exclude changes that would require extensive patient and public consultation, because really we wanted to make progress collectively, and we felt we could do that at pace and most easily by focusing on where there was clinical support across South West London, and indeed support from our patient representatives too. So we, for example, in the contentious area of fertility preservation techniques, including IVF, that is not part of what is set out in the 57 procedures in this document. And the final thing to say is we are, in this area, is we are linking to the work taking place across London, thinking about how our policy is best aligned with work taking place across the capital. You can understand, I'm sure, the challenge of getting 32 CCGs to agree a common policy. The challenge, of course, involving a huge amount of work to get 6 CCGs to a place of collective agreement. But there may be some procedures where it is best done, partly because of the nature of the provider, who might be a tertiary provider across the whole of the capital, to do that once across London. So we've carefully played into that London-wide work too, as part of the programme that we've undertaken. So the process that we've been to, and I'm sure Tony particularly and Nikki can say a little bit more about this, but the process was designed by local clinicians. I want to make that really clear from the outset. So as it was then, the clinical board designed the process that they thought was going to be effective, and we spent several hours actually in this room back in April plotting and planning the process that we would set out across the clinical groups that we needed to establish that made best sense from a clinical perspective. So we had one group that was set up around what is the process, so how should we develop the process to get to agreement on 57 different procedures across 6 CCGs. And that was a group that, as you can imagine, met regularly and had quite a lot of focus around it in order to do what it needed to do. There was a group that focused on existing thresholds that had already been enacted and in place for over a decade that required minor amendment. And that was a relatively pacey group, I think. There was another group that where there were existing thresholds requiring more significant changes, and you can imagine that that took quite a lot of time to look at the evidence where that existed from other parts of the country, to undertake benchmarking work, to look at activity levels, to look at clinical thresholds. So that group has been a significant part of this programme of work. And there was a fourth group looking at new clinical thresholds. So these are, we'll go on to describe, I think, the 7 areas shortly, but the additional areas where NICE or indeed other evidence has emerged over the course of the last decade, or indeed CCGs have taken on the commissioning responsibility over that time. So that's how we began the process. We've had Dr. Ash Paul, as I say, a dedicated public health consultant working with us for about 6 months to undertake this programme of work. And those papers have been discussed in length at those task and finish group, and it's been overseen by a weekly group that I have been involved in, and we have coordinated that, and we have presented the outputs of this work back to the Clinical Senate so that many local clinicians could reflect on the progress that we have made and check that they're assured that we have had a robust process. And it was very reassuring to hear the feedback from those clinicians about that process, many of them feeling that the task we'd set ourselves was a very challenging one at the outset of getting agreement across these 57 procedures, and really pleased that we'd been able to reach a clinical view that that was the right way forward collectively across southwest London. So I think that's something to be really pleased about. The next slide, which fortunately members in the public gallery may be able to see more clearly because it's on rather a small screen for everyone else, but it's really just a snapshot of the key people involved in the work. Actually, there's too many people to name on any single slide, so my apologies to you if you were extensively involved in this work and are not included on this list. But you can see there is a vast array of people from local providers, from local commissioners, from patient and public engagement steering groups, and indeed others who've been involved in this work, as well as, I know, the governing bodies and representatives from the 6 CCGs. So the next slide, in hopefully a relatively easy to understand format, sets out by clinical area the 57 procedures that are incorporated in this policy. And of course, we're going to make this information available very readily to primary care clinicians, both in hard copy and electronically, to support them in their decision making as we move forward. Because we're well aware that the primary care and indeed the secondary care workforce continues to evolve every year, and there's a need for continuously remind people coming into southwest London as clinicians what the policy is, what it incorporates, what's new and different from where else they may have worked in the past. So we will, and we're very committed to ensuring that there's a clear process of refresh and clinical engagement, and ensuring our comms campaign really meets the needs it needs to locally. So the next slide, I think, really summarises the feedback that we receive from the Clinical Senate. As I've already noted, there were many positive comments, and I think actually if we are able to get to that place, it's great that South West London has been able to step together through this process. The majority, in fact, almost all the changes requested were in the presentation of the document to make it more readily understandable and more user-friendly for the clinicians and others who will be using this document. There were a handful of minor clinical questions, which you would expect as people test rigorously whether we have the right policy in place and the right thresholds. But there was no view emerging from primary or indeed secondary care colleagues that there ought to be a significant amendment to clinical thresholds from the version of the policy that was reviewed by the Clinical Senate when they met a month or so ago. And of course, that feedback, and we warmly welcome that feedback, has been incorporated in the revised policy that's before you this evening. So to bring it a little more to life in terms of the clinical engagement in this process and how we went about aligning clinical thresholds, and also to talk through some of the additional or new clinical thresholds, I'm going to ask Dr. Brzezinski to talk us through the next couple of slides. Tony, over to you.
So thank you very much, Jonathan. So to summarise, our ambition was to give the best possible outcomes to the most people. We know from the significant evidence base that procedures are carried out for different reasons, only one of which is patient need. Others include societal factors, clinicians having beliefs that are outdated, patients who are having beliefs that are unrealistic, and so on. So we know from the evidence and data from our contracting performance that there are significant differences in the same operation, as the numbers of the same operation being carried out in different parts of southwest London. These aren't explainable just on clinical need, and in many areas they're significantly higher than best practice clinical pathways would indicate. So clearly, to get the best possible outcomes, we needed to look at how we could reform what we were doing and how we could do that across southwest London as a patch to ensure that care was equitable and fair. We do know from other government processes, such as the right care data, that outcomes also vary from CCG to CCG in southwest London, and clearly that isn't ideal either. So we have looked here at thresholds, but not service provision. So clearly some services need large-scale transformation projects such as musculoskeletal service and redesign, and this policy will underpin the ongoing work that needs to be done to develop these systems. So moving on, for each threshold, we undertook a clinical review based on the existing template to review whether that was current and up to date, but also looked at evidence from NICE and other published evidence, including international evidence, with the help of our consultant. At the discussion prior to making the decision amongst the CCGs, we included the main providers and consultants of these services to give their views and to inform the discussion in great detail, and sometimes there was significant input on this. Once we had discussions in draft, these were circulated to all the clinicians in southwest London via the medical directors, and any feedback from any consultant in any speciality for which we had included as a potential threshold was responded to and acted upon, and that was hugely valuable. So that's part of the process. I'll talk a little bit about the evidence base. There is a substantial evidence base and bibliography for each of those thresholds that we haven't included. That's all available, and if anyone wishes to look at it, we're more than happy to supply it. I think it would probably be too heavy to bring, and there'll be a health and safety issue if we printed all those papers out for here today. We've tried to make the policy much more user-friendly. Often there were inconsistencies, and in some place academic and not patient-focused. Many clinicians reported they did not know where to look for thresholds and found the amount of information overwhelming. So we've simplified this in conjunction with patients on the various groups, clinicians including GPs and secondary care, and most importantly have included a simple information sheet to GPs known as the primary care advice section, so GPs have a clear idea of what thresholds are and what they mean. But certainly, most importantly, we've included patients in all of the group, including Carol in my group, which was the groups 3 and 4. We've tried to make the language simpler wherever possible and to rationalise the clinical thresholds. So, for example, we have one for a small volume service called blepharoplasty, which is fine if you're a clinician, but basically means eyelid surgery, so we've called it eyelid surgery. I've spoken about the evidence base, but because to get the best outcomes, patients must really clearly understand their condition and what is likely to benefit their condition. For that reason, for every single one of the thresholds, we've put emphasis that patients should be properly informed and be able to make a properly informed decision about whether they wish to have their procedure or not, instead of being told by a clinician that they must have a procedure. We know that in one CCG that operations for hips and knees are done on lower symptoms than other parts of the country, and as a result, because people aren't so unwell with their hips and knees, they're more dissatisfied with the outcomes for their operations because the operation probably wasn't the right part for them. So it's important that patients know what they're signing up for and they know the benefits and the risks of the procedures and decide whether to go ahead with them. Clearly, if they don't want to go ahead with them now, and they change their mind later, that's an option open to them. We're looking to try and offer a pathway of care to offer conservative treatments wherever possible that will benefit patients instead of just expecting a procedure or an operation to be the final cure. So, for example, if you have knee or hip osteoarthritis and you're in pain, if you're unable to exercise and improve your muscle tone and can't try and lose weight, providing your disability allows you to, then you're highly unlikely to do well, even if you have a hip or a knee operation, which will be seen as a cure, because without the muscle support and less pressure on the joint by having a low weight, you will have a poor outcome. So it's about trying to put procedures in a clinical pathway. We're looking for evidence-based that we improve quality of life, and clearly that patient involvement in that process is key. So we introduced a few new procedures. So that's the next one. So we carry out a very large number of hernia repairs, about 2,500 a year in southwest London. We know from work that date backs a long time, from John Jack Wenner and others, that if you counsel patients and patients make a decision, over half of adults opt not to have a hernia operation. This is a condition that for most doesn't impair on the quality of life, and it may well be that is part of the reason we have poor outcomes if people have surgery for a condition that isn't troubling them in the first place. The ECI policy should also provide assurance to CCGs and the patients that they are expected to benefit from the procedures they will receive, which isn't the case necessarily at the moment, or we're unable to assure ourselves that that is the case. We've made similar advice for hemorrhoidectomy, where the variation is even greater, although we do a relatively small number of procedures per year. Hip impingement is a recently recognised condition, which wasn't in our original list 10 years ago. It's a very narrow specific indication, but we are spending significant sums of money on very large numbers of patients on the grounds of hip impingement. Clearly this is difficult to understand, and it may well just be a coding issue, but it's important that we make sure the right patients are getting the right procedure, and so that for that reason we have included this as one of the criteria. Obesity surgery is being moved to CCGs to commission going forward, so this is something we haven't yet addressed, but the bariatric surgery is at the end of a long pathway of care, and the underlying pathway isn't in place everywhere and may not be actually very well evidence-based, so we felt unable to do that piece of work until we have the full pathway resolved. And finally, the last area are Bartholin cyst surgery. So Bartholin cysts are an embryological remnant in the vulva of women, which sometimes can become enlarged. Removing them, if there are no symptoms, can cause significant lifelong symptoms in up to 20% of women. So it's important that women make an informed decision about how they can manage their condition without surgery if possible, and that if surgery is undertaken, what the potential complications are. So I think that's me. Over to you, Jonathan.
Thank you very much, Tony, for bringing that to life for us. So a really important statutory duty CCG have is around ensuring equality of access to services. So we feel inherently that by reducing the unwarranted variation that there is in existing policies, we will be able to demonstrate greater equality for local residents through what's been set out here. But of course that wasn't enough, and we felt very clearly that we wanted to undertake a proper equality impact assessment. And we asked an an organisation at some distance from us, the North East London Commissioning Support Unit, to actually take a look at the impact that this would have on local residents to ensure that we'd fulfilled our legal equality duties. So we undertook the first phase of that assessment process against all 57 clinical procedures, as you would expect us to. And as a result of that work, the group recommended that in 7 areas we ought to undertake a full equality impact assessment, which has been circulated to members of this committee. And those 7 areas are listed on the slide, and indeed some of those are topics that Tony has talked us through. In those detailed assessments, I think the area of equality impact that they wanted to flag was that a lot of our documentation is produced in English as a sole language, and of course for some communities English is not their first language, and we ought to reflect on that in some of the communications literature that we produce aligned with this policy. With that caveat, they strongly endorse the view that this it drove improved equality of access to patients across southwest London. So I thought, given it's a formal statutory duty, it's quite important for this committee to be aware and note the feedback that we've received from the Commissioning Support Unit in that regard. So I'm sure committee members are really keen to hear what happens, assuming we collectively sign off this policy this evening, and what are the next steps. So we would obviously notify providers that a new policy was coming into place across southwest London. A lot of it will be familiar to them because we have an existing policy that we've been refreshing, and that will take some time to build the electronic templates and the processes that allow information to flow between primary and secondary care. But the intention would be that the new policy would be enacted on patients referred from the turn of the calendar year, so from very early January 2018. And we would also need to think, and indeed are already thinking through, as we have done over the last 6 months, how we make the best use of the resources employed in this area. So how we use the resources that CCGs have, how we use the resources of the Commissioning Support Unit, who provide some of the administration of this process, and how we use the 6 GP federations who I've encouraged and have been working collectively around this and provide greater resilience, because obviously there's a larger number of clinicians involved by them working together to provide an ongoing service for patients. I think it's probably reassuring to committee members to know that just in the last 6 months, as we've been reflecting on the previous version of the policy, more than 2,500 patients have gone through that process, and more than 95% of those patients have gone through that process in less than 72 hours. So ensuring that we have a rapid response to patients and it doesn't have an impact on the time to their treatment. I also think there's some further opportunities that we ought to explore across the 6 CCGs in southwest London. And the first, and I touched on this at the beginning, of course, patients quite rightly, particularly if they have a strong case that demonstrates exceptional circumstances, have the right to ask for an individual funding request and that to be reviewed. We often do that in individual CCGs rather than collectively, and there's an opportunity to integrate what we call the prior approval process. That's the process that supports the implementation of this policy with the individual funding request policy, and make better use of our collective resources and scarce and precious clinical time through that. And there's also some opportunities to build some technology into those processes. So a lot of this process already takes, or all the prior approval process takes place electronically, but there was probably opportunities to build that even further and extend it into the individual funding request process too, to make decisions in a more timely way for patients. So that's where we are at this point in time in terms of the next steps, subject to agreement this evening. And at this point, I think it's right to hand back to you as convener and ask for questions from members of the committees.
Thank you very much, Jonathan and Tony. As I said, I will now seek a first cut of comments from each chair of the CCG groups here tonight. So if we start with Sutton. Any comments? You don't have to.
So I'm not needing to add a comment other than just to say that through our own mechanisms of Sutton CCG, we have engaged an enormous amount of clinical engagement in supporting what we're doing here tonight.
Again, it's just a comment about the process and the involvement of all the clinicians. I think it was a very thorough process involving clinicians from provider, so hospital consultants, as well as clinicians from the CCGs, and the discussions came to a conclusion, and what you're seeing here is the conclusion.
Thank you. Is it too soon for you?
It might be a bit soon. Apologies for being late. Can you leave me till the end?
Yes, I think from Croydon, I think the clinical leaders, the CCG chair, other medics within the CCG itself have all been engaged well within the process. ECR policies is something that's been looked at in Croydon over the past few years anyway. It's been presented to a lot of the GPs in some meetings, so it's a process that we understand well. I think in terms of the policy that we're looking at now, we've been fully engaged, and we're happy with to sign this off ourselves.
Thank you.
Thank you. From a Merton perspective, I can confirm certainly that my clinical colleagues are all very satisfied with the level of engagement that we've seen in this process, and particularly we're assured by the public health expertise that's been applied to the process. I think that's really helped. Is it time for questions now, or? Okay. Thank you.
Thank you. So from a Wandsworth CCG point of view, we very much welcome the development of a policy which seeks to ensure that patient care is safer and is evidence-based, and that results in reduced variation in care. So this was really important to us. And I can confirm that we approved the process for agreement, and that we've had significant clinical involvement in this, and assurance to our organisation, our board, about the process and the clinical involvement that's happened has been robust.
So, in Richmond, I can confirm that our clinicians have been very engaged in this process, and we support the process and the methodology that was used. I think the main thing for us is actually communicating it with clinicians and making sure that clinicians understand the process, and also, how we communicate with patients going forward. So we would support some, clear comms out to patients as well. Okay, but our clinicians are very engaged in ECI. Thank you.
Thank you very much. I'm now going to open it to the floor to members and participants around the table. Karen, I think you got in first.
Yes, I'd actually like to ask two questions. The first actually follows on from what's just been said. I'd like to ask what the process of support will be for GPs in implementing the process, and also whether there will be a facility for GPs to feed back if they are coming across any particular issues. So that's my first question. And the second question would be, how is the policy going to be kept up to date as new guidance comes out? So sorry.
Nikki, do I see you? Or
So I think it's probably most appropriate that one of the GP colleagues answers the questions about how it impacts on GPs and primary care.
Want to go first?
So we've thought a lot about how we support GPs with this, and I think a lot of it will be education. And you saw one of the slides, so producing easy, accessible information, so something that sit on their desktops that they can see which I think the big feedback is which procedures actually fall under the policy, and remembering 57 of them when you're in a busy surgery, so quick access to that information. We're also looking at developing forms for GPs so that they can quickly send the important supporting evidence they need to send. And absolutely, we want feedback on what they find difficult.
Thank you.
Implementing.
No, I would agree with Nicola. We've tried to make the process as simple as possible for GPs. Where GPs are able to collect supporting evidence and send it off, we hope that'll be done as automatically as possible, using tools such as DXS and so on, which we would expect to be rolled out across the whole of South West London as we go, and rationalise referral into our trusts. As far as keeping the process up to date, we're well aware that medicine changes and we need to evaluate the effectiveness of this programme. So we've agreed at all of the meetings that we would look at the outcomes from the meetings, whether we were seeing improved outcomes, whether we were seeing a reduction in variation through the process. If we felt the process was not working well, we would review it, and if it added no benefits, we may remove the threshold altogether. Alternatively, if the world changes and evidence changes, then we'd also then be in a position to have evidence from what has happened in the previous 3, 6 months or 9 months, a year in South West London to decide how to make rational changes going forwards, either to increase or decrease thresholds, which we haven't at this time got. So keeping it up to date and using the data that we generate from this is absolutely critical for ongoing care, particularly if we're looking to roll this process out in other areas, because I think we've found a process that has worked very well. It's very patient focused, and Carol and others were members of the group who are in the audience today. I hope they would support that view.
Just on that second question, because I think that's so important after we've done all this work, how do we keep the momentum up and the learning from this? So we've certainly, as an alliance of CCGs, committed to putting the right resources in place, and I've already talked about what we've done within CCGs, with the commissioning support unit and with GP federations to try and embed that going forward. We've said we will have an annual review process. We will commit the resources within the alliance to ensure that there are people who will keep us focused on this. And indeed, if we do as CCGs commit to look into new areas, like how we could better integrate this with individual funding requests, for example, that of itself all keeps up the momentum. I don't think we can underestimate the value actually of getting such a wide range, more than 50 clinicians, just to work together across South West London. I really hope they wouldn't let us not keep up the positive momentum that we've put in place. It's also worth saying the directors of public health have asked exactly the same question as Dr. Wellington has asked, and I'm going to meet with the directors of public health across South West London in December, because I think it's really important they help us keep up to date with the guidance too.
Stephen.
My question's been answered, actually. It was the same question.
Okay.
As one of the people who was on the Group 3, the existing thresholds requiring more significant amendments, and representing patients, I have to say there were some very robust discussions at that meeting that I shared with Carol and Joe. And I felt very assured at the end of the discussions that the patient was very much going to be talked with and have a very clear understanding of what the treatment options were. And that is really important in this whole process. Without that step, the whole thing will not work. But with that step, I think we've got a really robust, strong approach here. So I'm very happy with it.
Thank you, Claire. Questions? Right, well, we are asked to agree the policy, the policy, ECI policy version 2. I think just for formality's sake, we will go around by CCG to see if you agree. Sutton?
So I confirm that Sutton CCG supports the new ECI policy.
I confirm Kingston CCG support the ECI documentation.
Richmond?
I confirm that Richmond CCG supports the ECI document.
Thank you.
I confirm that Croydon CCG are happy to sign off the ECR document.
Thank you.
I confirm that Merton is happy to support the policy too.
Thank you. Wandsworth is happy to support and approve this policy.
I was involved with Claire and Joe and others in the various groups over the summer. There was a lot of hard work done, and as Claire said, some of the discussions were robust. There was a huge input from clinicians via, some turned up in person, all sorts of communication via email and phone-ins, lots of involvement. I also would like to thank Public Health, the Public Health contribution, and Zali for the team. It was a huge help to, the project couldn't have happened without the public health input, and it made a huge difference. And I'd also like to thank Surrey Downs, who was involved with the processes group of the project, because they had gone ahead with some of the processes a year ahead, and they were very heavily involved in this project, and it was very helpful indeed. So thank you to everybody. There are probably hundreds of people around Southwest London who were involved one way or another in this, and it was a very important project. So I'm delighted we've agreed it. To the public for questions. We did, excuse me for just one written question.
I don't know if we've got the person that wrote the question, but I think Jonathan has it there, and I think he has
Okay, Jonathan, just the part.
Okay, so I'll read out the question. I don't know whether Pauline Gorman is...
Yeah, okay. I can actually read my own question.
Oh, well, that would be even better, wouldn't it, Pauline?
I'm surprised that it's not been... I'm surprised that it's not been circulated or printed up as I put it in a couple of days ago, and that opportunity arises for you. But still, actually, I might even slightly amend it, because since I've been here and seen the second draft of the report, it's not really a comment or question on the report. Standardising care and treatment obviously is important, though we might ask why it's been done piecemeal through the country and it isn't actually national policy. But my chief comment or question to these committees is that if you meet, and I don't think you meet very regularly, you must be aware that there are 20 billion cuts in the next year's NHS budget, next 5 years NHS budget. And the Chief Officer of NHS England has described this level of cuts as impossible.
Excuse me, we are taking questions on the agenda items tonight, and we have been talking about the effective commissioning initiative. This is off the subject, I'm afraid.
So are you intending to have meetings of these CCGs in which you will discuss how you will face the cuts? Because my concern is that there'll come a point at which these procedures cannot be delivered because there isn't the funding for them.
This committee, this is the first and only time this particular committee has met. Jonathan?
So Pauline, thank you very much for your question. So you started to outline your question, and I think there's an aspect of it that is pertinent to the conversation we're having this evening, and that's the bit that I wanted to be able to respond to, if that's okay with you. I think there's then probably a written response that will be required around other aspects which are not for the discussion this evening. But and it was at the start of your question, you were really saying the report before us has an impact and a reduction in care, potentially linked to the £20 billion. That's how your question began. The report before us details reductions in care, which are the CCG's share in £20 billion worth of cuts in the next 5 years. So I wanted just to say a little bit about, I think we've tried to explain through the course of the conversation about this is really a process about how we use evidence and try and achieve equity for patients across South West London. But I did want to, if it's okay with you, address your point about are we trying to do this to save money, which I think was at the epicentre of your question. Are you happy to...
That's a part of it, but it's also how the CCGs are going to respond to the fact that they probably can't deliver.
So can I
Yeah.
at least if I could respond around the ECI policy, which is the decision that we've asked the committee to make,
which is what we're dealing with tonight
this evening. So as I was saying, the whole purpose is to ensure that it is evidence-based and clinically effective what we're doing, and access to treatment is as equitable for people across all the boroughs of South West London. It's clearly at the moment there is variability in access to some services, and sometimes that's above the national average, and sometimes we can't really explain why that is and understand why that is. And what we're trying to do is apply these clinical thresholds in the same manner and a consistent manner across South West London, and to ensure that patients don't undergo procedures where there isn't the clinical evidence to support that happening to them. And I think that's only right and actually a moral duty. I feel that as a member of the public and patient, as well as a member of this conversation this evening. And to give you an example of that, people who have obstructive sleeping disorder are often undergo surgery where there's plenty of evidence that if they reduce their evening intake of alcohol, are encouraged not to sleep on their backs, and other techniques, they will not require surgery. And I think it's really important that in the examples I gave and some of the examples Tony gave earlier, people only undergo procedures when they need them to happen. And also in the context of your question and the huge financial challenge that Simon Stevens, the Chief Executive of the NHS, has outlined, it's really important we make the most value out of each NHS pound that we have, given some of the challenges that we face. And this will help us do that by ensuring that there is an evidence base, that we treat patients on the basis of clinical needs. So it's probably better for a clinician to articulate that, but I did want to give you a formal answer to your question because you were kind enough to send it in to us before this evening. I think other aspects of the question, which aren't apposite to what we're talking about tonight, probably need a written response, and I'm sure our convener will say a little bit more about that.
So I'd just like to come back to the ambition of the whole programme, which, to put things into jargon, was the right operation, the right patient, at the right time with the right outcome. So that is the nub of it. That was the tenor of every discussion we had, and at no time were there any financial targets or savings discussed, and at no time did we ever look to see whether there would be savings or costs involved. We set out thresholds that were relevant for patients who wanted to or might be eligible for treatment, and we made sure that every time a patient has one of these procedures, they're properly informed about it beforehand. So a bit more information just to pick up on Jonathan's example, which I've only just heard. The surgery for snoring is generally something called a palatoplasty, which is an operation on the hard palate at the top of your back of your mouth. It is the most painful operation known to man, and anyone who's had it, not me, would contest to that. 75% fail by the end of year 1, and men are snoring, usually men, or not exclusively. And so if they're reoperated on, 75% of those who are reoperated on are snoring again by year 2. So if we gave that information to patients before they had this procedure, instead of being told there is an operation and no alternatives, I wonder how many patients would opt for that procedure and whether we would need thresholds at all. So we're looking at changing the whole temper of how we do planned and elective care. It isn't just about it's not at all about making money or restricting care.
I can add, and I'm sure Claire and Joe will join in on this. Money did not come into these discussions. We were looking at equity of access, and in some cases it may cost more if there's equitable access. It was simply not a factor in the discussion. I'm sure a written response to your question will be forthcoming at some point. Thank you. The second question.
I've got a couple of questions actually, but also a point of detail. At the start of the meeting, you mentioned declarations of conflicts of interest in which people are expected to give their own possible conflicts or conflicts of close members of the family. I'd like to ask the convener, who's the lay member for Wandsworth CCG, if she's the same Carol Verlin, who is the director of Wandsworth Care Alliance and St George's Trading Company Limited.
The answer is I was, but I have ceased my term with both those charities. I no longer have a connection with either St George's Hospital Charity or Wandsworth Care Alliance. They were fully declared when I was a trustee of those charities.
Okay, thank you for that. Moving on to my question, is the new threshold on hip and knee operations, is that likely to have an impact on the success or otherwise of the Swellyock Centre in Epsom Hospital, which is apparently a centre for marvellous hip and knee surgery? Is this new threshold likely to affect the viability of that unit, or are people going to be forced to have these operations privately instead?
So the thresholds are set at quite a low level and are decided upon who's going to benefit from the operation, as we've already outlined. I doubt that it will have any significant impact on the Elective Orthopaedic Centre, as it's now called, who were fully part of the consultation process and gave input, as did every other trust performing orthopaedic operations in South West London and indeed Surrey Downs. So these are consensus guidelines. They're less stringent than in other parts of the country where weight was put in as a restricting factor, body mass index. We felt that was manifestly unfair, and we did discuss this because it's very difficult to lose weight if you cannot walk or move, for example. And similar restrictions that others have about not operating on smokers, we also thought was manifestly unfair if they suffered from pain. So I hope that answers your questions as fully as possible clinically.
Well, I did think that earlier you actually said that being overweight would affect the likelihood of you benefiting from an operation, and in fact you wouldn't get it if you were overweight.
No, that's not what I said at all.
Okay.
I said that being overweight will reduce the effectiveness of the operation because it puts considerable strain on the joints. Clearly, the advice up front would be to try and advise patients to lose weight, to build their muscle strength up and get as fit as possible before operation, but that wouldn't be a determining factor whether or not they had the operation. It's not intended to delay the operation, and it is for to advise patients how they can help themselves, because it's about them at the end of the day, not the surgeon doing the operation.
Okay, thank you for that. It's not what I understood you to say, but okay, thank you. Last question. Is it true that this group is intending to move forward to become an ACO, and thus transforming our National Health Service into a group of separate units, which the formation of which has got no political or parliamentary authority? In fact, there's a legal challenge to that very procedure going through as we speak.
if I...
So I was going to say that that isn't the subject of the meeting, but I can say that there is no intention in this group to become an ACO. If at any point we should change our minds about that in the future, then we would be talking to people about that and making that clear. But there absolutely is not. We are 6 CCGs working together. This group is making a decision on something that we need to make together, and that's the intention of tonight's meeting.
And indeed, we are limited by our terms of reference to specific items agreed by the CCG boards.
And none of the CCG boards have decided to become an ACO? Is that what you're saying?
None of the CCGs in South West London decided to become an ACO. Any intention to change organisational structures would be discussed at governing body level and would go through a process. At the moment, we have no intentions to change any of the organisations that we have.
Thank you.
Any further questions from the public on tonight's agenda?
Mine wasn't a request, just you mentioned about the clinical evidence. Could you make that available for public review? The doctor who mentioned about the clinical evidence. Yeah,
So-
could you
so-
make sure it's available publicly, please?
Yes, of course. We're very happy to do that. So, so the policy, I think, is available for people to see tonight. But what we were talking about, what Dr. Brzezinski was talking about earlier, of the detailed assessment of clinical evidence, it's, as you imagine, it's a very large tome of documents. But I think that's perfectly possible for us to find a way of posting that electronically, so people can review or indeed links if that's more appropriate to the evidence base. So very happy to try to find a mechanism to do that.
Can I just say, I think there's two parts to this. One is the actual detailed clinical evidence that they used in order to make the decision, which we can make available, I'm sure, on a website somewhere. I think the second bit is how do we talk to patients, and I think we are looking at how do we make sure that that's really easily accessible for people, that they can get access to that when they're talking to their GP, and that's a slightly different type of information, but something, so not a lot of people will want to look through lots of nice guidance and clinical evidence from international studies and whatever they've used to make those decisions, but absolutely patients will want to know, actually, will my outcome be better if I do it like this? You know, that the information that Dr. Brzezinski has given on snoring, you know, you'd want to know that as a patient before you make a decision about your operation. So that information will also be available in a much more accessible way.
Fine.
I'm saying it's both, but I'm saying we need to do both, is what I'm saying, yeah.
My question, or perhaps it's just a comment really, was that when I read through the document, which I accept, I did not have a lot of time to read before I came here, I didn't really have a sense of how many of the changes fell under the Category 2 minor amendments and how many fell under Category 3 sort of major amendments. And I wondered if there was a document that set that out in a easily digestible form. And can I just carry on? And it seems to me that when the whole communication thing happens and information is produced for patients, it might be as well to have some sort of clarity over that. Because if something is a small change just to bring it in line with what 5 other CCGs are doing, or whether it's a bigger change that's for probably, you know, I accept good reasons, it might be just helpful in terms of communication.
I can give you a rough outline, so not exact numbers to be quoted and me to be hung by if they're wrong. So we looked 57 areas, about 94 policies and all, or something of that order. Of those, about 10 were major changes or new policies, and all the rest were minor variations, variations in spelling, minor differences in wording.
I mean, I think that kind of information is actually quite useful to know.
Yeah, thank you for that.
I just wanted to say that actually when you talk about communication with patients, I think what we were really looking at was that the main communication would be directly doctor to patient, that would be the point of the real discussion about is this the right route, the surgery or whatever. So it's not necessarily that we will be, my understanding anyway, that we will be publicising a massive change, but that it's face-to-face change. Was that just my understanding?
Nikki, can you?
I think what you'll actually find is is actually comparing the old document with the new document, not asking you to go through each one, obviously, but is that it's much clearer, and the primary care element of this will enable GPs to have a much clearer discussion with the individual patient about the new thresholds, because they're all much clearer. So that's what most of it was. There were a few where we had bigger discussions, and but actually most of them didn't end up with major changes. And I suppose it's the question that you want is where we will show where we have had big changes.
So the ones we had big changes were on the slide that Jonathan spoke about, that we spoke to. Some were new, and some were variations on existing policies, but that was the group 3 or 4, which is a relatively very small number of policies. Most of the others had been in use extensively already, which in clinical practice makes no difference, but the policies were worded or were more confusing, and they've been clarified, simplified, made easier to use, but will actually have very little difference on either trusts or patients, apart from the fact that we'll be putting in that information for patients so they can make an informed choice about what they're letting themselves in for.
Of course, we can provide details of what was in Group 2 and Group 3, but I think it's really important to say about 50 clinicians were involved in assessing what was in Group 2 and Group 3, so it was a clinical process. What I thought might be helpful is I've just put the slide up when we were talking about the equality impact assessment, and these 7 areas are the areas where there was most clinical debate, or indeed there was an issue that took up some considerable time in Group 3. So that provides, it's not necessarily an entirely comprehensive list, but it provides a strong indication of the areas where there was more considerable debate because either there was new nice guidance, changes in practice over the last decade, or because there was genuine clinical debate that clinicians wanted to have in South West London about what's the right threshold.
Hello. My understanding is that this body here is a part of the machinery to carry forward implementation of the STP in South West London. Is that not correct?
So this is where we need to make, and that's why it's called the Collaborative Decision-Making Committee, is when we decide in South West London that there is a decision that we want to make together. And that is the sum of what this committee is. And we will only pull it together where we have a decision that we want to make together. We will only do it with the agreement of the individual CCGs.
That's not what I asked. Is this part of the machinery to implement the STP? Yes or no, please?
The STP is not a formal body. What this committee does is it is there to make joint decisions together. So that's what it's for. If there was a decision within the STP that we wanted to make together, it might come to this committee. There may be lots of decisions that we make within the partnership, which is the STP, that we make individually. So I couldn't say yes or no to that because I don't think it's a yes or no answer.
I think you simply don't want to admit that that's exactly what this is. Now then, the STP requires demand moderation, and I'm very concerned when you talk about equality impact. What we're looking at is the implementation of a race to the bottom across all CCGs. What's the least amount of clinical provision that you can deliver and be no lower than the lowest?
With great respect, I don't believe you've been listening tonight, if that's what you think you've heard.
Oh, yes, I have. Yes, I have. You have been talking about changing thresholds. Can you confirm that the net impact of the new revised thresholds will not be a reduction in the overall level of provision?
So, as I've explained, there's a difference between listening and hearing. So I think I've tried to explain as clearly as possible that it was done to get better outcomes for patients and operate and offer patients the right pathways of care, and that at no time in any of the groups was a restriction in demand, financial targets, or anything of that ilk discussed. I'm not sure I can be any more clear than that.
That's actually not true, because I was present at a CCG meeting, and I'm not sure now whether it was Merton or Sutton, I'll look back at my records, but there was extensive discussion about curtailing the provision of IVF in the same week that St Helier Hospital opened its brand new IVF centre, and there was a long discussion about the cost impact of restricting or ceasing provision of IVF. It was discussed at length.
IVF is not
Sorry,
part of this
sorry.
policy.
This policy has, as we have set out very clearly and was in the presentation, we are not including IVF within this policy. So nobody has said that, and nobody has made any intention around that. This policy is the joint policy for South West London, and it excludes that explicitly. So I think
because consultation is required. That's why it excludes it, because they were forced. The CCGs were forced to accept the council's insistence that it goes to public consultation. That's the only reason it's not part of this now.
So this is not part of this piece of work at all.
I turn it on, he turns it off. Thank you all very much for your attention tonight. Thank you for the team for producing an excellent project. Good best wishes to all in implementing it. We have quite a bit of work to do. The process group meets again on Monday, I believe. Thank you to members of the public for coming along. Thank you. Good night.